So introduction, we'll look at introduction of fever, and we'll follow this outline. We'll look at infectious causes and non-infectious causes, and we'll go on. So let's start with introduction. Fever is a very common finding in the ICU, and all of us that have worked in ICU would have come across patients with fever. So it's a very common sign in the ICU, and it can arise from various causes, including infectious and non-infectious causes. And our discussion this evening will border on both infectious and non-infectious causes of fever. Fever, as we know, is associated with increased mobility and mortality in ICU patients, and actually forms part of many mortality prediction scores in ICU, including our popular Apache 2 and Apache 3. All right, according to the American College of Critical Care Medicine and Infectious Disease Society of America Joint Task Force, a fever in ICU is defined as a single temperature greater or equal to 38.3 degrees Celsius. All right, this is kind of different from the general definition of fever. And it said that fever should only be investigated in an ICU patient if the temperature is equal above 38.3 degrees Celsius. We must bear in mind that in our neutropenic patient, the definition for fever should be different. Okay, we should have a lower threshold for definition of fever because these patients lack the ability to mount up inflammatory response or fever response to infection. So if a single temperature more than 38.6 or a temperature more than 38.0 degrees Celsius that is sustained for more than 1 hour, all right, in a neutropenic patient with absolute neutrophil count less than 500 cells per millimeter should be regarded as fever. All right, note that fever is different from hypothermia, hyperparesia, which is a temperature that is more than 41 degrees. And this is not common in our ICU patient, except some cases that are abnormal. But most of the times, temperatures ranging above 31 degrees may occur, but not common in our patient. So fever, the incidence of fever in many studies ranges between 26 to 88%. And this incidence depends on the type of ICU, maybe surgical, medical, neuro ICU and all that. And also depends on the cohort of the patient you're looking at, and more importantly, on the definition of fever that the authors are looking at. So, but a wide range between 26 to 88% of our patients in ICU have fever. In actual sense, one study by Lampard showed that the incidence of fever in the medical and surgical ICU was between 48 and 8% respectively. All right, showing that patients in surgical ICUs tend to have lower incidence of fever. Another study found similar incidences of fever between infectious and non-infectious causes, and this was reported by these authors, who found that the incidence of fever in their surgical ICU was about 26%. I'm sure most of our ICUs anecdotally would agree that this incidence is lower than what many of us encounter in our different places of practice. Now, so I wrote, I said, fever is not always an enemy. Fever is not always a foe, because fever has some beneficial effects to the patient. All right. So, number one is that fever, high blood temperature, helps to inhibit the growth and replication of pathogens, bacteria, and viruses. And so, fever also enhances the activity of your immune cells, such as neutrophils and macrophages, and this helps the body's ability to fight off infections. Fever also can lead to the production of heat shock proteins that tend to protect cells from stress and damage. So fever is not always a foe, and as we go on, we realize that in treating fever, we need to analyze the risk-benefit ratio for our patients. All right, there are different patterns of fever. I rather say all fevers are not the same. And the fever presents in different patterns, and observing these patterns may sometimes help us in diagnosing the underlying cause. For instance, bacterial infections usually come down with continuous fever. The temperature remains elevated with little or no fluctuations. And a lot of times, if you look at your chart, most of the nurses' chart, they give you temperature by the hour. And once you see bacterial infection, you will see that the temperature remains consistently elevated over a period of time. And this points to bacterial infections. Sometimes we have intermittent fever that is common in malaria endemic regions where there are series of temperature spikes which return to normal. Viral infections come down with temperature that fluctuates, and but does not return to normal at any point in time, and that will give you an indication of viral infection. Some fevers may, relapse. You have days of fever, you have days with normal body temperature, and this can be seen in bacterial infections like borreliosis. So fever patterns can help to give a pointer into the cause of fever, the pathogens, and whether the fever is of infectious or non-infectious origin. All right, measurement of body temperature, especially in our patient. Let's agree here that peripheral body temperature measurement using sites like the axilla or oral and forehead should not normally be used in our ICU. And if I do a survey, a point survey now to find out how many of us have means of monitoring core temperature, we may be shocked that many of us still rely on peripheral body temperature. That shouldn't be. So core body temperature should be the way of monitoring and measuring temperature in the ICU. And I like mnemonics, so if you like mnemonics like me, you may want to write down points, all right, size of core temperature measurement, point. Now we use the pulmonary artery catheter thermistor. Know that this is considered the gold standard, but rarely used in ICU because it's invasive. Esophageal point, intra-abdominal, like your bladder and rectal, sites sites of monitoring core temperature, and these are commonly used because they are convenient to use. Nasopharyngeal and tympanic membrane are the other sites where core temperature may be measured. So just remember points. If you can get your pulmonary artery catheter thermistor, especially when a lot of people do not even pass pulmonary artery catheter, you may want to use nasopharyngeal tympanic membrane, or even the lower esophageal, lower end of the esophagus may be used. So core temperature measurement should be the go-to in measuring and monitoring temperature in our ICU patient. Now, so let's look at the approach to a patient with fever in the ICU. There are two groups, generally, two groups of patients that would come with fever. Those patients who present with a febrile illness, they are admitted to the ICU with fever already. So you want to find out if there's a focus of infection that is identified, or this fever is undifferentiated. There are some patients who develop fever during the ICU stay, and you want to find out, is this fever of infective or non-infective causes. We'll see this as we go on. Like I mentioned, so if a patient is admitted to the ICU with a fever already, at the point of admission, the temperature is above 38.3, you want to ascertain the focus of infection, maybe in the lungs, or you're dealing with community acquired pneumonia, or meningitis, for instance, or urinary tract infection. So you want to find out that this patient can with fever, what is the source of the infection. While patients in ICU may develop fever, and many of them develop fever, and most of the time this is secondary to health care associated infections such as your VAP and your CLAPSB and all that. We're going to be looking at this. So when you see a patient with fever in ICU, you want to ascertain that this patient come with fever or did this fever develop during the stay of the patient in the ICU. All right, so if the patient, let's look at patients who develop fever in the ICU, and we're going to find out, is this fever of infectious cause or non-infectious cause? And we're going to be looking at some of them as we go on. The infectious causes, the common infectious causes of fever that develop in the ICU, we have ventilator-associated pneumonia, we have central line-associated bloodstream infection, we have catheter-associated urinary tract infection, surgical site infection, and the Clostridioides difficile. All right, this usually comes down with diarrhea, pressure ulcers. Then we look at fungal sepsis. These are some of the common causes of infectious cause of fever. Then it's also possible that a patient could come down with fever of non-infectious origin. And I like mnemonics, so I put Monday there. As a common question I ask my residents and people who run with me in trying to decipher the origin of this fever. So Monday, it could be malignant hyperthermia, myocardial infarction. It could actually be malignancy. O stands for operative fevers, fevers that develop about 2 to 3 days post-op. We could be neuroleptic malignant syndrome. A lot of times we have, patients who are on haloperidol, patients who are on metoclopramide. This patient may actually come down with neuroleptic malignant syndrome. Some patients may develop drug fevers, others may have adrenal crisis in ICU, and patients with hepatitis. And this is why it's important for us to look at the cause of fever. Serum amylase and lipase may actually help to differentiate fever resulting from pancreatitis and other causes. So let's look at the first one, the first infectious cause of fever, ventilator-associated pneumonia. Most of our patients, mechanical ventilation is one of the commonest indications for ICU admission, be it post-op or medical cases. And when a patient has been on mechanical ventilation for longer than 48 hours and the patient comes down with fever, our index of suspicion should be high as to ventilator-associated pneumonia. And this can either be early if the pneumonia develops within 5 days after hospital admission and institution or initiation of mechanical ventilation, that would be early VAP. But if the pneumonia develops after 5 days, all right, this will be late, and all of these have different outcomes. All right, so what are the risk factors? VAP3, what are the risk factors for ventilator-associated pneumonia as a cause of fever? Number one, ventilation, invasive ventilation with endotracheal intubation, and the longer the duration of ventilation. And that's why one of our common practice is you start weaning the patient the very moment you put the patient on ventilator. And it's one of the reasons is to prevent VAP. Elderly patients with age-related changes in lung function and weaker immune responses are prone to develop VAP more than the younger ones. Patients who have had prior antibiotic use, maybe patient with community-acquired pneumonia, now needing ventilator, patient has been on azithromycin or other or ciprofloxacin at the outpatient department, and when the patient comes to ICU for ventilation, this patient are at higher risk of developing ventilator-associated pneumonia. Poor oral hygiene, and this is something we're going to look at as part of the prevention bundle of ventilator-associated pneumonia. Position in patients who are supine, all right, position supine has a higher risk because they are prone to aspiration of gastric contents. All right, so how do you make a diagnosis? Your patient has fever, your patient has been on ventilator for more than 48 hours, and you're thinking that means this patient has developed ventilator-associated pneumonia. You want to look at, based on clinical assessment, what is the temperature and all that. You want to look at leukocytosis and the patient requiring higher ventilatory support. You want to obtain your trachea aspirates, for MCS, and then you want to do chest X-ray, which will show new or progressive infiltrates that was not there earlier on. Sometimes, if you are not able to get copious secretions from the endotracheal tube, you may be able to get some lavage from the bronchoalveolar lavage in order to identify the causative pathogens for this VAP. All right, it's important that you start empirical therapy, antibiotic therapy, for especially for patients who develop VAP less than 5 days, on admission, and your cephalosporins, the second or third generation cephalosporins, will be helpful for late VAP. All right, or when VAP is suspected to be due to multi-drug resistance pathogens. You want to use combination therapy like your ceftazidime, cephalosporins, and your carbapenem may be useful in this group of patients. But remember that the optimal duration for treatment of ventilator-associated pneumonia should be a minimum of 8 days, especially for the late VAP developing. Now, one way to also, look at diagnostic criteria for ventilator-associated pneumonia is what we call the clinical pulmonary infection score. All right, that has these six different parameters. You want to look at the temperature. You want to look at the white blood cell count, the chest X-ray. You want to look at secretions, whether they are minimal, moderate, or profuse, and you want to look at your tracheal aspirate or your bronchoalveolar lavage to see whether there are any pathogens that are cultured. Then you look at your oxygenation index, your PF ratio, and this will help. So a score greater than 6 is suggestive of ventilator-associated pneumonia, and that will make you to start empirical antibiotic treatment. All right. There's what we call prevention bundles, infection prevention bundles, and each of these healthcare associated infections have different prevention bundles. And it's been found that implementing VAP prevention bundles can help reduce ventilator-associated pneumonia in half of our patients, and that's very significant. So it's important for us to familiarize ourselves with these prevention bundles, as it can go a long way to reduce the incidence of VAP in more than half of our patients. So HOTS, all right, ensure that all your ventilator patients are positioned head up, about 30 to 45-degree forward position. All right, it's important because we found out that patients who are positioned supine, have greater risk. Also, prophylaxis, thromboprophylaxis, because most of these patients are immobile and they have increased risk of thromboembolism. And it is important that we ensure thromboprophylaxis for this patient. Very, very important is sedation vacation. All right, regularly, every day, you want to assess the need for sedation, and you give your patients every day sedation vacation. Like I dream in my practice, I tell my nurses stop sedation by 4 to 5 a.m. so that by the time we're starting around by 8, 9, it will be good for me to be enough time to assess the patient GCS and readiness to wean off the ventilator. Sedation vacation, daily sedation vacation is a very important component of ventilator-associated pneumonia prevention bundle. Suctioning, preferably closed system suctioning to maintain ASEPs is crucial, especially for ventilator-associated pneumonia bundle. safe cuff pressure, all right, ensure, I don't know, many of us have a pressure manometer that we can use to constantly monitor our cuff pressure, especially the cuff of our ETT or tracheostomy tube. Very important is the selective decontamination of the digestive tract. And here we're more concerned with proper oral care with chlorhexidine. So maintaining these 5 to 6 prevention bundles will go a long way in ensuring that we reduce the incidence of ventilator-associated pneumonia in our patient. All right, so let's continue. Somebody just distracted me with that. I hope I still have. Can you still see my slide?
Yes, sir.
Is my slide still showing? Sorry.
Yes, sir. We can see you.
Still showing.
Okay,
Yes.
great. Thank you. So the second infectious cause of fever is the central line associated bloodstream infection. Most of our patients in ICU have a central line institute for different indications, but it's possible that pathogens can colonize your catheter and subsequently enter the bloodstream, and this can just be the cause of the persistent fever that your patient have. So diagnosis, you want to do blood culture, which is obtained from your peripheral blood and catheter lumens. It's important that blood is taken from the catheter lumens. All right. So you want to do quantitative or semi-quantitative culture of catheter segments. I always insist that once we're suspecting CLABSB, that catheter, that central line catheter must come out, and we send a tip for MCS. Sometimes radiological imaging may be used to assess for evidence of catheter-related complications such as thrombosis or abscess formation, and this may just be the needles for the infection. Remember that the diagnosis of Class B depends on demonstration by culture of the same organism from the catheter tip and blood culture. Let me repeat this. This is important. Before we can make a diagnosis of Class B, you must demonstrate by your culture the same organism, all right, which has colonized the catheter tip, has entered the bloodstream. A colony count of at least 3-fold greater for blood obtained from the catheter hub, or a differential time to positivity test of at least 2 hours at the catheter hub indicates Class B, catheter central line associated bloodstream infection. All right, how do you manage this? The first thing is you want to remove and replace the catheter. Ideally, if if Class B continues despite initiation of antibiotics 72 hours after, it is important that that catheter must come out and not just replace, site the catheter in another place. I know sometimes we're handicapped and we just want to reroll the new catheter into the existing one. But if it's possible, resite your catheter somewhere else. Fourth generation cephalosporin and carbapenem combination is crucial. And one of the common organisms causing Class B is your methicillin resistant Staphylococcus aureus. So a gram-positive blood spectrum antibiotics, vancomycin, will help in this group. Remember that if you suspect Pseudomonas or you culture Pseudomonas, you want to use aminoglycoside, and the duration depends of the organism. There are lots of complications that may arise from central and associated bloodstream infection, but if you do identify complications, you may need to prolong your antibiotics for at least 28 days. So, like I mentioned, healthcare-associated infections have different prevention bundles. So the Class B prevention bundles is here, and I try to make it simple for us by using Class B as the mnemonics. So the mnemonics for Class B prevention bundle is also Class B. The C is clean hands, ensure that you adhere to hand hygiene during insertion, during the care of the central line. Many of us we inject drugs, we draw drugs from the central line, without care for proper hand hygiene. Is important before you touch your central line catheter or the insertion site. Ensure you adhere to strict hand hygiene. Review the line regularly. Most of the times, I insist that we use a transparent dressing. Your them transparent dressing. You can actually see where there are evidence of infection around your catheter. Number two, you want to always review, does this my patient still require central line? Is this patient on TPN? Is it on vasoactive agent? Or am I going to give, toxic medications to this patient? Anytime that you are not convinced your patient requires continual presence of central line, you remove it. Maintain asepsis all the time in and around the catheter. Barrier precautions, all right? When you are sighting your central line, make sure you ensure barriers, street barrier precautions, sterile gloves, mask, gown, and drape is important. All right, you must ensure, especially I tell my nurses, nobody passes central line without adhering to barrier precautions. You must put on your drape, you must gown, you must put on mask, you must wear a sterile glove. Pay attention to the sites of insertion. All right, you must keep clean and cover. A lot of times, when we're doing central line, you want to measure street asepsis by cleaning, the area with iodine, spirit, and all that. Inspect the central line all the time, every day, for any sign of infection or other issues. This has been found to reduce the incidence of Class B by more than 66%. So by adhering to this prevention bundle, we can reduce fever that ensures from central line associated bloodstream infection. All right, the next healthcare associated infection that account for infectious cause of fever in our ICU is our catheter associated UTIs. All right, it's usually diagnosed when you have a bacteria with 10 to power 3 colony forming units per mil. All right, and there are associated symptoms like fever, renal good tenderness, hematuria, and all that. You have, especially for patients who have prolonged catheterization in the ICU. All right, risk factors for catheter-associated UTI include prolonged catheterization. For every catheterized day, the increase of CAT increases significantly. And this is important. A lot of times we want to check, part of the COTI bundle is to check, does my patient still require urethral catheter? All right. So insertion technique is important. How do you catheterize your patient? All right. And catheter care is also very important when, especially for our nurses who are doing regular urine collection for input and output documentation. And how do you place your urinary bag? It's important the urinary bag is below the bed so that you prevent reflux of urine, infected urine, back into the urethra, into the bladder. Patient factors can actually also predispose them to developing catheter-associated urinary tract infection. Patients with diabetes, patients on immune suppressive drugs, or who are immunocompromised. Female patients, because the length of their urethra is smaller, and they are all, these are factors that increase their susceptibility to catheter-associated UTIs. So diagnosis, we can run through this. We have so much to talk about. Let me just rush. So the management, remove your catheter remove your urethral catheter if it's been more than 2 weeks maximum. All right. I know that we have silicone catheter that can stay for months, but most of our ICUs do not have silicone urethral catheter. The normal Foley's catheter should not stay more than 2 weeks. All right. And if we cannot discontinue, I ask some people use condom catheter just not to be invasive. They don't want to put the catheter through the urethra. So some use condom catheter, but it creates a problem for the nurses because it's difficult to then collect hourly urine for input and output. Antibiotic therapy, especially when you suspect catheter-treated urinary tract infection, and you can do your urine culture in order to determine the specific pathogens. The common pathogens that identify the E. coli, Klebsiella species, Pseudomonas aeruginosa, and that will make you to want to give your a broad spectrum antibiotics that target gram-negative um, pathogens or bacteria. Duration of therapy is usually between 7 to 14 days, but also you individualize your patient because the responses may be different from one patient to another. All right, so prevention bundle for CAR-T, it's also CAR-T, like I said. So catheter insertion, pay attention to catheter insertion. Proper techniques and guidelines are always followed. Maintain asepsis throughout the insertion process, during and any interactions with your urethral catheter. Now, avoid unnecessary urinary catheterization. All right, avoid it. Always is this important. I am only going to catheterize this patient when it is indicated. All right, if the patient can void, all right, why put a catheter there? Remove the catheter as soon as it's no longer needed. We shouldn't put a catheter, leave a catheter there for convenience. We remove the catheter as soon as it is no longer needed. Inspect your catheters. A lot of times we can see cloudy urine coming out from catheter. Sometimes if you look at the urethra meatus and the entrance, you can see that sometimes they're already colonized with pathogens. So it's important to inspect your catheter on a daily basis. It's been found out that CAR-T prevention bond adhering to these bundles help to reduce the incidence of catheter-related urinary tract infection by as much as 70%, which is a lot. So we can save quite our patients from the horror of fever resulting from catheter-related urinary tract infection. Now, the next one is the surgical site infection. All right. Now, these are infections that occur around the site of surgical incision. Most of our patients, a lot of us admit surgical patients, and we need to understand that fever sometimes can result from surgical site infection, and it can be superficial, deep, or even organ, which has to do with any part of the anatomy that has been manipulated during surgery may come down with fever. Please, Wisin, you are defacing my, oh my God, you are defacing my slide, my presentation. Please, let's be careful because I'm saving this for future references. Somebody has just screwed on this now. This is not fair. Please, let's desist from it so that it's difficult to remove afterwards. Thank you. Now it stays there. It's difficult to remove now. Surgical site infections, diagnosis, you want to look at signs and symptoms of infection, all right, which could be local or systemic. You want to take swab from the wound or tissues for culture and sensitivity, and sometimes imaging studies such as ultrasound or MRI may be necessary to assess for infections that are deep-seated or sometimes abscess. They had a patient recently in our ICU, surgical patient who had gastric perforation and came down with septic shock on double vasopressor and on antibiotics, broad spectrum antibiotics, but the patient wasn't getting better, and we found out that this patient had abscess collection intra-abdominally, and we were able to diagnose this with the use of ultrasound. So imaging studies may help you to identify the source of infection. And remember that as long as the source is there, no matter the antibiotics you are flogging the patient with, the patient will not get better. All right. All right. Somebody said, thank you for the presentation. Is the VAP bundle indicated for people that are intubated? Yes, yes. VAP prevention bundle is not for VAP, it's to prevent VAP. Thank you. All right. So, how do you manage surgical site infections? Antibiotic therapy. You start empirically until you get your culture sensitivity result. Surgical debridement may be necessary, especially to remove infected tissue, drain abscesses, and which will also help to improve wound healing. Wound care, both intra and post-operatively, is important with adequate irrigation, debridement, dressing. All right, a lot of times there are a lot of dressing that take place in the ICU. How is this done? These are things we need to concentrate on. So, the prevention bundle, all right, don't forget it's the SSI. So you want to surgical site preparation, intra-op, all right, disinfect the skin with appropriate antiseptic solutions, start antibiotics, all right, sugar control because elevated blood sugar leaves room for growth of pathogens that especially in diabetic patient. Surgical technique is important and you must also inspect your surgical wound. A lot of times we just concentrate on our ICU care. We need to also look at the surgical wound if it's still clean or requires the surgeons to come and look at the wound. Instituting SSI surgical site prevention bundle has been found to reduce almost half incidence of surgical site infection. Now, this is very important, often overlooked in the ICU, and this is Clostridioides difficile infection, all right, which leads to watery diarrhea in our patients in ICU, all right. Clostridium difficile is a gram-positive spore-forming anaerobic bacterium, all right, and it causes head care-associated diarrhea in our patients. The spores of this bacterium colonize and survive the acidic environment of the stomach, reaching the intestines. All right, this leads to diarrhea, arising. Sometimes antibiotic use disrupts the normal gut flora, all right, which reduces the resistance of the spores colonizing the intestines, and this allow the organism to proliferate. And importantly, just like your Clostridium tetani, Clostridium difficile produces toxins, which can damage the intestinal epithelium, leading to inflammation and diarrhea. All right, clinical presentations of CDI is WAFI. You have watery diarrhea. All right, a lot of times our patients come down with watery diarrhea, frequent loose stools. All right, abdominal pain. All right, fever. All right, in most cases, fever, and you have leukocytosis. Many times CDI is not just diarrhea with electrolyte derangement. Many of them can come down with severe, serious complications like toxic megacolon perforation, and septic shock may result just from CDI, Clostridium difficile infection. All right, there are different ways to look at it. You do a stool test. You can do enzyme immunoassays where you detect the toxins A and B. PCR is very sensitive. You can detect the toxic genes. And endoscopy, you may even be able to find pseudomembranous colitis, all right, especially in severe cases. Treatment: discontinue the inciting antibiotics. Most of the time, antibiotics like cephalosporins, your gabapentin can actually incite CDI with diarrhea. So antibiotic therapy, vancomycin is the drug of choice, especially in severe CDI, because the organism is gram-positive or spore forming, so you want to use a broad spectrum antibiotics target gram-positive anaerobes. So supportive care, make sure you rehydrate your patient, and if there are any electrolyte imbalances, you want to take care of it. Oral surgeons may come in, especially if we have complications like toxic megacolon of the perforation due to the toxins that has been elaborated in the intestine. There's prevention bundle for most of them. Close it, close it. So clean hands, limit antibiotic use, ensure you observe contact precautions with glove and gowns. Make sure you clean and disinfect surfaces and equipment in the rooms of patients who have come down with CDI. All right, educate and train staff about CDI's transmission and prevention. Patients who have CDI, Clostridium difficile infection, we need to use dedicated equipment for them. All right, and it's important that we implement surveillance programs to ensure that we are monitoring the incidence and the progress of the infection. Pressure ulcers, these are very important. In fact, this is a critical incident that is reported. All right, so they are very common serious complications in the ICU patient. In fact, some studies have reported more than 60% incidence of pressure ulcers in our ICU patient. And how do they develop? By sustained pressure, all right, of the body. It compresses blood vessels, leading to ischemia. And this ischemia will produce tissue hypoxia, leading to tissue damage and cell death. All right, and this damage has released inflammatory mediators, exacerbating tissue injury. So this is how pressure ulcers develop, and it's important for us to understand the risk factors. What are the risk factors that can make your patient come down with pressure ulcer? Mind it. All right, moisture. All right, from incontinence, perspiration, wound exudate, all this can weaken the patient's skin integrity because the patient has limited mobility, either due to sedation or muscle paralysis, or even as a result of the severity of the illness or the injury. Poor nutritional status impairs skin repair, and patients who are either not tolerating or are poorly fed can predispose them to pressure ulcer. Devices, your tubes, drains, can exert pressure on the skin. All right, and this can lead to tissue hypoxia and necrosis. Patients, especially elderly patients, patients with thinner skin, reduced tissue elasticity, all increase susceptibility to pressure ulcers. Patients with comorbidities like diabetes, patients with vascular disease, and patients who are hypotensive, all this lead to poor peripheral circulation, and they can actually lead to poor healing, and this will predispose your patients to pressure ulcers. All right, because of time, look at pressure ulcers. How do you manage it? Regularly evaluate the size, depth, and condition of the ulcer while you're also looking for evidence of infection. Need be, you may need to debride, all right, either using surgical or enzymatic method. Dress the wound appropriately to maintain a moist wound environment, absorb exudate, and protect the wound. Antibiotics, systemic antibiotics for infected ulcers, and sometimes you may want to use topical antimicrobial agent. Most of the times we don't use this topical agent. Systemic antibiotics will take care of it. Remember that this is painful. A lot of times we forget that though they are sedated or they are unconscious, they don't feel pain. No, they do. So adequate analgesia will help to improve patient comfort, and we can get their cooperation during therapy. Adjunct therapies like negative pressure wound therapy is very crucial. It helps treat pressure ulcers, improve healing. Therapies like growth factors and barbaric oxygen has been used in selected cases. All right, for your non-healing ulcers, especially grade 4 ulcers, surgical intervention with your plastic surgeons may be indicated. All right, so pressure ulcer prevention bundles. All these are prevention bundles. These are time-tested, evidence-based steps that should be taken together in order to prevent the occurrence of these infectious causes of fever. So press F, all right? Risk assessment using the branding scale for as your patient comes into the ICU during admission, you want to assess their risk of developing pressure ulcer. We'll see it in the next slide. Skin care and inspection at least once a day. And you want to focus on those prominent areas and areas of risk. Keep your patient's skin clean, all right, all the time. Make sure you give them high protein and calorie rich supplement as needed and adequate hydration. Position your patient, reposition your patient at least every 2 hours. Most ICU nurses are good at this. I'll give them kudos for ensuring that their patients are repositioned every 2 hours. I'll use pressure relieving mattresses. In third world, I don't know how many of our ICUs have alpha bed or those pressure relieving mattresses and cushions to relieve pressure on dependent areas. As much as possible, encourage and assist with early mobilization and ambulation as much as is appropriate. All right, this is the branding scale I was talking about. It's a widely used, validated prediction score, all right, for pressure ulcer risk, all right, and it looks at 6 parameters: the sensory, moisture, activity, mobility, nutritional status, and friction. All right, each criterion is scored from 1 to 4, and the total score ranges from 6 to 23. The lower the total score, the higher the risk of developing pressure ulcers in your patient. If you're interested, you can go through this. I just put it there for us to see. All right, for instance, now the sensory perception, you want to check the ability of your patient to respond meaningfully to pressure-related discomfort. All right. So if there is a limitation, all right, the patient cannot respond to pressure limited discomfort, you give 1. All right, very limited, slightly limited, and there's no impairment. The patient moves with every discomfort. All right, you give the patient 4. Remember, the lower the score, the higher the risk. You want to check for degree to which the skin is exposed to moisture. If the skin is constantly moist, it's 1. The skin is occasionally moist, you give 3. If the skin is rarely moist, you give 4. You want to look at the degree of physical activity of the patient. Is it bed fast? Can you move your patient to the bed to the chair once in a while? Does this patient walk occasionally? These are things that you can look at. I'm sure once you have the slide, you'll be able to go through it again. Yes, very important aspect of fever in ICU is consideration for fungal sepsis. And fungal sepsis poses a significant challenge in the ICU. A lot of times they go unnoticed right under our nostrils. And I felt it's important for us to remind ourselves that fungal sepsis is a significant cause of fever, infectious fever in the ICU. And the common pathogens are the Candida species, with the Candida albicans being the most frequently isolated in fungal sepsis. We have other non-albicans species like the Glabrata, Paraciliosis, and Tropicalis. All right, they are being increasingly implicated, especially in nosocomial infections. Aspergillus fumigatus Cryptococcus neoformans. This is very an important fungal species in immunocompromised individuals, and they can cause cryptococcal meningitis. Other fungi agents are the dimorphic fungi, which can cause endemic mycosis that can actually lead to disseminated candidemia and sepsis, especially in patients with low or weak immune system. Fungal sepsis is difficult because fungus have a way of evading the immune system. All right, they invade the immune system, so the immune system can recognize them, and they go into the cell, into the bloodstream, and cause sepsis or candidemia, as the case may be. All right, they can also elicit immune response from the host with activation of pro-inflammatory cytokines, the interleukin-1, interleukin-6, and tumor necrosis factor alpha. And all this can lead to systemic inflammatory response syndrome. All right, they can invade blood vessels and organs, causing tissue necrosis, especially worse when they invade the brain tissues. And as they invade the immune system, they also suppress the immune system, making them go unchecked as a cause of sepsis in our patient. Patients with fungal sepsis obviously will come with fever, and this fever, listen, when your patient is on broad spectrum antibiotics for more than 7 days and fever is persistent or recurrent, just put your mind on fungal sepsis. Let me repeat that. If your patient has been on antibiotics for a week and the fever is not breaking or is coming and going, there might just be some fungal sepsis lurking in the corner. So look at it. And many of them, they come down with severe sepsis, with septic shock, requiring double strength or double vasopressor. Many of them can actually predispose your patient to multi-organ dysfunction syndrome. A lot of times when our patients are not responding to your antibiotics and they come down with MODS, it may just be fungal sepsis that are coming. A lot of times our patients in ICU have skin rashes that may be a pointer to underlying fungal etiology. And that's why it's important to always expose your patient from head to toe in as much as the patient is under your care in the ICU. All right, diagnostic strategies. Blood cultures have very low sensitivity for fungemia. All right, so what we use is we use serological tests which tries to detect fungal antigens or antibodies in the blood. All right, tests like galactomannan for aspergillosis, beta-D-glucan for fungal marker are commonly used. So serology is the way to go, especially in detecting fungal sepsis. Polymerase chain reaction-based assays offer rapid and specific identification, and sometimes imaging technique may be used to identify invasive fungal infections and guide biopsy for histopathological exams. So antifungal therapy, all right, we have the caspofungin or mecafungin, which are the echinocardins, azoles like the fluconazole and the voriconazole are preferred, especially for invasive aspergillosis. Amphotericin though very toxic, can be a critical option, especially for cryptococcus meningitis. A lot of times we may required to have combination antifungal agents, to enhance efficacy and prevent sepsis. Now, this is important. I do this often, and I want to encourage us. If your patients have been on antibiotics 5 to 7 days without significant improvement, you want to calculate your candida score. All right, this is important. Candida score helps to identify patients who are at risk of invasive candidiasis in the ICU. And they have 4 components. Candida score is made of 4 components. If your patient is on total parenteral nutrition, it gets a score of 1. If the patient had any surgery, especially surgeries in the GIT, you get 1. That means it has 1. If there's multifocal, maybe in the mouth or in the urogenital system, there's some fungal colonization, the patient have 1. Now, if the patient has come down with severe sepsis, the patient has 2. So when you calculate your candida score and the score is less than 3, you can be sure that, okay, there's a low risk of invasive candidiasis. But if the score is equal or greater than 3, there's a high risk, and that is when you want to start empirical antifungal therapy. And I've discovered that once we start empirical antifungal therapy in our patients, especially with fluconazole 200 milligram daily, the patients do well and they seem to be responding, and fever is coming down, and the requirement for vasopressor is reducing, and you've saved the patient just because you have a third eye. So in managing patients with severe sepsis or septic shock, it's important for us to have a third eye, which I refer to as your candida score. All right, these are just antifungal agents we can use. Now, we've talked about infectious causes of fever, the common health care associated infections. Then we have the non-infectious causes. Like I said, all fevers in the ICU are not infectious. All right. So common causes of non-infectious causes of fever include the Monday that I told you before, the malignant hyperthermia. All right. This is a life-threatening metabolic reaction. All right. And that actually results from triggering agents like anesthetic agents, and may also be found, is common in patients with mutations in the ryanodine receptor. All right, this confers MH susceptibility, and this could be a cause of fever. But most of the time, this fever, is as high as 39 degrees Celsius. All right, it's associated with muscle rigidity, and the hallmark of it is that all these symptoms develop almost immediately after exposure to your triggering agents, whether your anesthetic agent or your relaxant. If you do laboratory tests, you'll see elevated CK, hyperkalemia, there will be presence of metabolic acidosis. The definitive test, obviously, is the caffeine halogen contraction test on your muscle biopsy. All right, so how do you deal with this? You want to stop all triggering agents? All right, dantrolene, which inhibits calcium release from the sarcoplasmic reticulum, is indicated here at a dose of 2.5 milligram per kg. You may need to repeat it as often as is required. All right, supportive care with rapid cooling, temperature as high as greater than 39. You want to use ice packs or cold intravenous fluids. Correct metabolic acidosis. Some of them, they have pH between 7.6.8 to 7.1, and you want to treat hyperkalemia, with release of potassium into the cell. Continuous, most of the time, this patient should be admitted in ICU for observation for at least 24 to 48 hours. Myocardial infarction is another non-infectious cause of fever that we all know, but remember that myocardial infarction can result from different causes, and especially in diabetic patients, you can have silent MI because of the peripheral and central neuropathy that these patients have. Just make sure that you are on guard when it comes to myocardial infarction. They also will come with fever because of the myocardial cell death and the inflammatory response that it elicits. All right. Another common cause of non-infectious cause of fever is your operative fever or your surgical fever. Also, and it refers to fever occurring after surgery. All right, and it may result from SARS due to trauma or the surgery. All right, or even pancreatitis can trigger this inflammatory response. Inflammation, all right, intestinal paralysis, atelectasis, post-operative immobility, or hypoventilation can cause atelectasis, which can lead to low-grade fever. DVT thrombosis, can cause fever with leg swelling. Hematoma can cause, local inflammatory response, and all these things can predispose the patient to operative fever. So how do you manage this? Hydration, ensure adequate fluid intake, mobility, encourage early mobility, and make sure you give your antipyretics, incentive spirometry. All right, with deep breathing exercise will help you to prevent atelectasis or treat it. All right, supportive care like including bowel rest, nasogastric decompressions are some of the measures for post-operative fever prevention. All right, the NMS we mentioned before is a rare, potentially life-threatening conditions, and they are all medication related. Some of our patients we use haloperidol to manage agitation, delirium, and some of them we give them metoclopramide as part of our ulcer prophylaxis. Now, after withdrawal of some of these drugs used for Parkinson's may precipitate neuroleptic malignant syndrome, and this can cause fever, hyperthermia, as well as sometimes above 40 degrees Celsius, associated with muscle rigidity, autonomic dysfunction, and altered mental state. All right, so you discontinue the causative agents, supportive care, cooling measures, and pharmacological agent, which are dantrolene, will help with rigidity. All right, drug fevers. All right, these are fevers induced by your medications. Sometimes you're using antibiotics to treat the infection. Antibiotics can actually cause drug fever, and there are so many other drugs like that can lead, like penicillin, cephalosporins. These are antibiotics that can induce fever. There's what they call the drug fever syndrome. All right, where fever develops after initiation of a drug without evidence of infection, and this fever resolves immediately after you discontinue the offending medication. Common culprits, like I mentioned, penicillin, cephalosporins, anti-epileptic drugs like your phenytoin, especially we prescribe phenytoin for our TBI, post-op neurosurgical patients. They can actually induce fever in our patients. Ibuprofen, naproxen can actually cause it. All right. Some atypical and typical antipsychotics. These are common drugs that have been implicated in drug fever. Just one of the ways to look at it is once you give your patient a certain medication and fever develops almost immediately afterwards, that is the offending medications you need to look at. All right, clinical presentation, elevated blood pressure without any evidence of infection. You may have other associated symptoms, including rash, which may give a pointer to drug allergy with fever. Timing of the fever is important, like I mentioned before. When fever occurs shortly after you initiate the drug, after prolonged use, it is pointing to drug fever. So how do you manage? You discontinue the offending medication, supportive care like your antipyretics and fluid, and you treat symptoms that may arise, especially if it's due to drug allergy with your antihistamine and maybe sometimes your epinephrine. Close monitoring is important in this group of patients. Oh, there's a lot to talk about. Let me see. Adrenal crisis. These things will be available. Let's look at this. All right. There are differences between infectious and non-infectious causes of fever. Number one, the etiology. All right. Most of the time, infectious causes are caused by pathogens such as bacteria, viruses, fungi, and parasites. All right, the etiology of non-infectious causes of fever include autoimmune disease, like I mentioned before, the Mondays that we saw. The way they present also will distinguish them. All right, infectious causes will actually have, symptoms like chills and localized signs of infection, maybe cough, sore throat, and diarrhea. The clinical presentations for non-infectious causes may relate with the cause of the fever, maybe joint pain in autoimmune disease. Patients with malignancies may have weight loss, or there are specific drug side effects that you will see. In your diagnostic markers, the white blood cell will be raised, positive blood culture, urine culture, or during your serology, you may have specific antigen antibody test. All right, this will point to infectious causes. But when you have normal or non-specific changes in your white blood cell count, negative cultures, negative for specific markers of inflammation, you may be dealing with non-infectious causes. Response to treatment. If the fever typically responds to your antimicrobial therapies, mind you, I didn't say antibiotics, antimicrobial, so it includes antibiotics and your antifungals. All right, it shows that it's infectious causes. But for non-infectious causes, you will need to treat the underlying condition before there could be resolution of the fever. All right. Very importantly is that the fever in non-infectious causes seldom rise above 38.5. So when fever rises above 38.5, going to 39, most of the time the fever is of infectious cause. All right, so diagnostic approach to a patient with a fever in the ICU. All right, a patient develops fever when in ICU. So initial assessment, you want to do history. When did this fever start? 4 days, 2 days after initiation of mechanical ventilation, or 7 days after insertion of central line. You want to find out. All right, because that will give you a pointer to the healthcare associated infection you are dealing with. All right, you want to also find out associated symptoms. Maybe after the patient there's dyspnea, patient is now requiring ventilator and the settings are high. You may want to look at even the abdomen if there are some collections there. Physical examination will help you. You want to look at the level of consciousness, this conscious level, deep more than before. You want to look at the heart rate and all that. Focused physical exam, all right, based on your suspicion. You want to listen to the chest, for abnormal breast exams. You want to do lung sonar to look out for evidence of pneumonia, pleural effusion. You do all this before you order for investigations, and your full blood count. When there's a left shift in your leukocytosis, all right, this suggests infection and inflammation. Left shift leukocytosis refers to increased number of immature neutrophils, all right, in your peripheral blood. Left shift when there is an increase in immature neutrophils, and this is because there's a demand for neutrophil production. The bone marrow is producing more than a lot, and is releasing them into the circulation before they mature. So that's what we call left shift, and it's evidence of infection and inflammation. All right, you want to do two sets of blood cultures, one for aerobic and the other one for anaerobic before you start your antibiotics. You want to do basic metabolic panel, including and not limited to electrolyte, renal function, and lactate. Lactate is very important, high lactate. If you remember surviving sepsis campaign of 2016, lactate level was used as part of the oligo directed therapy. So lactate level is important in our patient. So if infective markers or inflammatory markers, your CRO protein and your erythrocyte sedimation rate, they are not specific, for bacteria, but they can tell you the presence of inflammation. Procalcitonin is important here because they are more bacteria specific. Imaging studies, chest X-ray, as is indicated. All right, you won't be doing chest X-ray for a patient that you suspect for catheter-associated urinary tract infection. So imaging studies, is ordered as required. So targeted microbiological tests, sputum culture, if you're thinking about ventilator-associated pneumonia, you want to do wound or abscess collection in case of surgical site infection. If there meningitis, anything that you can get from your history and your examination will determine the further test you will do. Now, the question here is, do we treat all fevers? Do we need to treat all fevers? This is important. When your patient has fever, you want to determine the risk-benefit ratio. All right. Treat fever if and only if the temperature is above 39 degrees Celsius. Number two, when you have a CNS insult, maybe following traumatic brain injury or patient with stroke, patient with poor cardiorespiratory reserve. Now, the reason for this is because fever will increase your oxygen demand, oxygen consumption, and this will impact on your cardiopulmonary reserve. So patients with poor cardiorespiratory reserve, like congestive heart failure or coronary artery disease, you want to treat with your antipyretic fever. External cooling with ice packs or intravenous fluid usually reserved for cases of hyperthermia. A lot of times, I remember those days in pediatric posting in undergraduate level, we were taught that fever is a good sign. So if fever is there, that means you're not dealing what you're dealing with. If fever is gone, that means you're doing well. So you need to measure the risk-benefit ratio. Do I need to treat this fever, or do I need to treat the cause of the fever? Now, treating infection, you start with empirical broad spectrum antibiotics. All right, we did antibiotic therapy last week. I'm sure you still remember that. All right, so we are at the end. We have the two case scenarios for our discussion briefly before I leave the floor open for questions and comments. Now, so the first case scenario, I want two people to volunteer to just quickly attempt to answer this as we draw close to the end. Now, a 65-year-old male patient is admitted to the ICU post-abdominal surgery for perforated diverticulitis. He developed fever, temperature of 38.5 degrees Celsius on the 3 post-op. Physical examination revealed a heart rate of 95 beats per minute, blood pressure 130/80 millimeters of mercury, respiratory rate of 18 cycles per minute, and is saturating at 98% on room air. All right, on examination, there's mild abdominal tenderness without rebound or guarding. Surgical site appears clean without erythema or discharge. All right, your laboratory test revealed white blood cell of 12,000 per microliter, blood culture expanding, and when you did your analysis, there's no evidence of infection. So, what is your diagnosis, and how do you go about managing this patient? So, anybody? Anybody wants to try? From all we have discussed, we must always talk about, unforeseen. Yes, go ahead.
All right, I'm thinking it might be verb.
VAP. Did you say VAP, unforeseen?
Yes.
But this patient is not intubated. This patient is not ventilated. What is making you think about VAP here? Patient is saturating at 98% room air.
I think I rushed into thinking about the days post-op, and I thought that was days post-ventilation. Sorry.
Oh, okay. All right. Does anybody have any other thing to say? Dr. Ichabod,
Yes,
do you agree?
Hi.
Hello.
Initially, the first thing which came to my mind was surgical site infection.
Surgical site infection? What makes you think about surgical site infection?
Because he's day 3 post abdominal wall surgery, so there was an incision which was made, so that could probably be a risk factor. In terms of respiratory, the findings, they are normal, saturating well, and the respiratory rate is within. Oh, surgical site appears clean. Okay.
Yeah, the surgical site appears clean, my
Hello.
brother, without the erythema
Very
or
likely that
discharge.
this is surgical site
Are you still
infection.
going
Very
with
likely.
your surgical site infection?
No. It's not surgical site
Okay,
infection.
I can see John Claude.
I think
This
this person has
probably
Can we have
fever
one
rather
person?
than.
John Claude, you have the floor.
So this is post-op fever, not site infection.
Beautiful, post-operative fever, correct. Now tell us why. How did you come about post-operative fever? And how will you manage it?
So this one, it occurs 3 days post-op, but according to physical examination, there is no features of peritonitis and there is no features of site infection. So I go on with the post-op fever rather than being an infection. And for the management, there's no need of antipyretics or paracetamol. So we just monitor.
Good, good. How many of you agree with John Claude? Any dissenting opinion? Siphon. Please go
I
ahead,
only
Siphon.
wanted to say I agree with him, sir. It's actually a post-operative fever. I agree with what he said. So that why I actually rest. No contrary opinion, sir.
Okay, correct. So we all agree this is post-op fever. Okay, this is post-operative fever. All right,
Yes, sir.
because it shows us 3 days post-op, we have fever. There are no evidence of surgical site infection, no evidence of UTI. The patient is not on ventilator. Just 3 days. This patient, even if the patient had a central line inserted, it's still just 3 days. So it will be difficult, and this patient does not have pressure ulcer. Okay, so this most likely a post-operative fever. The second case, a 45-year-old female patient admitted to ICU for septic shock secondary to pyelonephritis. She developed fever, temperature 39 degrees Celsius on day 5 of ICU stay. Fever is persistent despite initial empirical broad spectrum antibiotics. The central line has been in place for 7 days. Physical examination, heart rate of 110 beats per minute. Its blood pressure is 90, her blood pressure is 90/60. Respiratory does 22 cycles per minute, saturating at SpO2 of 94% room air. And when you inspected the central venous catheter side, there's some mild erythema and tenderness. So, how will you approach the diagnosis and how will you manage this patient? Anybody? Every hand should be up. I think the thing gave itself away. So quickly, who can try to approach this patient? Hey guys, we're quiet. Aminu Ahmad, please go ahead.
Sir, I think this is a catheter-related infection.
Sorry?
Catheter-related systemic infection.
Okay.
Yes,
Why? Convince us.
because the catheter has been there for about 7 days. It's kind of prolonged, and then the catheter site there is erythema and tenderness, showing some evidence of inflammation ongoing around the source of the infection, and then patient develop fever and the parameters tachycardia, respiratory rate, and blood pressure, hypertension are all evidence of infection.
Great. So how can somebody else tell us, how will you confirm that this is central line associated bloodstream infection? Somebody else, how will you approach the diagnosis for this patient. Thank you, Aminu Ahmad. I agree with you. It's central line associated bloodstream infection. But how do we confirm this diagnosis? Any other person?
Good evening, Prof.
All right, Dr. Nathan, go ahead.
You mentioned during your presentation to confirm the diagnosis that one, the culture from, you mentioned during the presentation that to confirm the diagnosis that the culture from the catheter tip, the organism must be the same with the blood culture.
Beautiful, yes. Okay, go ahead. What other ways? Nathan, any other person? Okay.
That's what I can pick up for now. And also from the inspection of the CVC, there is tenderness on that area, which can also contribute to it.
Okay, correct. So how will you manage the patient? Somebody else, how will you manage this patient? Are we all scared to talk? Time is going. Ichabod.
Yeah, you can use the same
That's from Malawi,
clubs.
I'm sure.
The
I remember your
acronym
name.
clubs. So you need to ensure that you perform hand hygiene, strict aseptic technique whenever you're performing the procedure for central line, including draping and inserting the central line itself. You should use at least antiseptic solutions for cleaning. Again, you can also avoid putting the central line via the femoral vein, which is close to the perineal area. That can be also a source of infection, and avoid prolonged stay of the central line in situ for a prolonged duration of time. And ideally, you should also remove the central line at least maybe for not more than 7 days. I've just forgotten the nitty-gritty details within the CRABS acronym which you gave us, but in a nutshell, I think this could encompass the CRABS acronym.
Beautiful, good job. Any other person specific management? Now, this patient has come down with class B. Some of the things you are mentioning is how to prevent class B. Your patient has come down with class B, centrally associated bloodstream infection. The only thing I hear that you mentioned is you remove the catheter. After removing the catheter, what again are you going to do? How do you manage this patient? Any other addition? Can we get an addition? Because we come across this all the time. Jean-Claude?
Yes,
Jonathan
for the management of
Mahango?
this patient.
Yes, anyone, go ahead.
So for the management of, we have to first remove the central line from the affected site, like those one with which has mild erythematous and tenderness. So we probably start from with vancomycin, IV vancomycin, as we saw that the most preferred gram-positive bacteria. So how to start vancomycin, remove the central line, and insert from another site rather than the infected one. Thank you.
Okay. Great. Why are you thinking about vancomycin? I'm not saying you are wrong. I just want to give me the reason. Dr. Mahango, you can come in, help your brother. Why is vancomycin? Why vancomycin? Do you agree or you disagree?
Good evening, Prof. I think he considered vancomycin because he was considering for methicillin-resistant Staph aureus.
Beautiful, beautiful. All right, beautiful. But you know vancomycin, how long are you going to give vancomycin to this patient? Okay, how long were you going to give vancomycin to this patient? Anybody? Because you are starting vancomycin as empirical broad spectrum antibiotics covering your gram-positive methicillin-resistant Staph aureus. So how long are you going to be on it, considering the fact that vancomycin has very terrible side effect? Those who have worked with me, you remember I told you the side effect of vancomycin. So how long?
So ideally, I would start vancomycin once I remove the indwelling catheter, central line catheter, and send it for catch and sensitivity. So once I get the catch and sensitivity results, and then I might stop the vancomycin and give drugs which have been sensitive to the culture results.
Beautiful. You want to de-escalate. That's what I want to hear. Once the culture sensitivity result is that you de-escalate to a narrower spectrum antibiotics. Good, good. So I think all right. This is a table. If you once you get the slide, you can go through it because of time. All right. You have a temperature. Your patient has fever. Temperature of 38.3. The first thing you want to do is that you want to look for obvious source of infection. Just put this flow chart in your brain all the time. There's a fever. The first thing I'm going to look for is this. Is there any obvious source of infection? If the answer is yes, you want to start appropriate diagnostic tests and start empirical antibiotics. All right. If the answer is no, and the temperature is more than 39 degrees Celsius, all right, if the temperature is more than 39 degrees Celsius, you want to think about your healthcare associated infection. You want to look at the central line. As the central line has been there for more than 48 hours, what do? You remove and you culture the tip. Is there ulnar tube like endotracheal tube? Remove and culture. Is there diarrhea? You do stool WBC and you test for serology for your Clostridium difficile. All right, then you continue downward with empirical antibiotics. Observe for effects of the antibiotic for 48 hours. If there's still persistent fever or progressive signs of infection is still there, think about antifungal. So what do? You do your candida score and do your antifungal and look for other causes like venography to rule out DVT and all that. So that is the right side. Now look at it. If the fever is not more than 39 degrees, it's just about 38.5. You want to think about your non-infectious causes. All right. And you observe for another 48 hours. If there's still persistent fever or progressive signs of fever, you want to escalate and treat with antipyretics. So this flow chart should always be on our mind as we approach any patient in ICU with fever. All right, these are my references, ladies and gentlemen. All right, so our first question, before we give room for any questions, our time is fast spent. It's actually a long, very long presentation. As Have we been able to achieve our learning objectives? Were we able to achieve our learning objectives? Anybody? Do you think you were able to achieve our learning objectives?
Yes, I think so, sir. Thank you very much, Prof. Yeah.
Okay, great. Great. All right. Any question, any addition before we call it an evening?
Sorry, okay. I just wanted to ask a question regarding the second case scenario you gave us, sir. I was also thinking, okay, the second case scenario you gave.
Yes.
Is it also possible sepsis in that patient, considering the fact that he has been on for more than 7 days?
No, but we're not told that the patient was on antibiotics for 7 days. But there's nothing wrong, you know. Like I said, before you start antifungal, you want to calculate your candida score. You remember what are the components of your candida score? 4 components. What are they? You remember the 4? The patient is the patient of total parenteral nutrition. Did the patient have surgery, especially abdominal surgery? All right. Does this patient have multifocal candida colonization? Is there evidence of severe sepsis? So if the patient has more than 3 candida score, you can start your antifungal like we mentioned. Okay. Did I answer your question?
Thank you, sir.
All right. Any other questions?
Thank you very much, sir.
Yes, Dr. Nick, you want to say something as we round up now?
Hello, good evening, Prof.
Good evening, Dr. Nick.
Please, I have a question. When you were presenting, you made mention that functioning of patients